You'll see here what the large group of rotations are in any given year that the trainees experience. In general, our applicants or our categorical residents have gotten their case numbers back to what they were like before the quote unquote 80-hour work week. Most of our graduates last year had a minimum of 1,100 cases. They get more than that if they want to get more than that, but there's no shortage of experience and certainly no concern about trainees being able to get the volume that they need to have a broad exposure and to feel confident at practicing autonomously. I just want to go over very shortly our resident education. There's a stuff that you'll find at every program. We have weekly grand rounds. We have weekly resident didactics that are protected on Thursday mornings right after grand rounds that are based on SCORE curriculum and are given by our surgical faculty for the most part. And then every single hospital has a mortality and morbidity conference that is a highlight of education for the trainees across the campuses. Those all practice and operate individually, although in the era of COVID, one of the nice things that's come from that has been the ability to connect between campuses and have a lot of Zoom conferences that allow increased educational access. At the Clifton campus, we have a Wednesday afternoon resident conference that's run by the residents, for the residents. When we say it's run by the residents, they largely organize the curriculum, but there's a large swath of faculty who engage in this conference. And it features journal club, board review, app site review, conversations about ethics, quality metrics, and we also run an acute care surgery report at that conference. There are site-specific resident educational conferences, so really robust and rich tumor board conferences across the system. In colorectal surgery, they have a monthly inflammatory bowel disease conference, again, that can be zoomed into. And Grady has really, for years now, put on a really beautiful oral board preparation for all of the residents, primarily focusing on our senior residents so that they're getting preparation year-round and not just when we hold mock oral exams. We have a simulation program that's fairly robust. It is run by Nick Papandrea, who's our Associate Director of Surgical Simulation based out of Emory Midtown, and Dr. Liz Benjamin, who's based out of Grady, is the Director of Simulation. At the Clifton campus, we have a small access area within our resident wing that includes an endoscopic simulator, a couple of FLS trainers, and a robotic simulator. In addition, we make sure that all of our residents complete their FLS certification midway through their second year. And we're trying to move our FES simulation or our FES formal testing earlier and earlier in the residency, because this is a certification that was only required in the last couple of years. It started off with us getting it in the PGY 4-5 levels. I would anticipate by the time that you all join the training program, we're going to really try to do most of the testing in the third and fourth years. And then we have a standardized robotic training curriculum. So this is a curriculum that has been created by our faculty who are specialized in robotics in conjunction with Intuitive, so that we meet certain metrics that may be applicable nationwide. But the most important thing is that it's a curriculum that has been designed by us and not industry, that we think is widely applicable to the trainees. If you want to be fully trained in doing robotics by the time you complete this residency, that's an easy thing to do. I will say, to brag a little bit, that for our residents who've specifically gone and done minimally invasive surgery fellowships, they've already given us feedback that they're ahead of the game compared to a lot of their counterparts. We run cadaveric training sessions in the fall. In non-COVID times, that would be running right now. We're working through figuring out algorithms to allow for that to be safely performed now. But essentially, we take about 25 component maneuvers. We have the residents led by a faculty advisor and a senior resident spend a day doing dissections where these are taught after they've done a couple of preparatory didactic sessions. And then later on, the residents are all tested either in the operating room or in a simulation setting where we video record them doing the dissection and reciting the maneuvers. We do something similar with laparoscopic coaching. We have created a number of simulated prescribed skills for various levels of PGY residents. And those skills are recorded. They are actually graded. That feedback is used to practice the skill for about a month, and the skills are re-recorded and then regraded. And we do that to look for a delta in performance and try to use directed feedback to improve the technical skills of the residents. One of the things that we found by doing this during the year is that residents are actually practicing their skills year round rather than just doing it in isolated patches. And then I just wanted to address very quickly some of the flexibility that's built into our program. So starting with the research years, I'm going to go in reverse order here, but the vast majority of our residents who want to do research will go into research after their second year. It is not mandatory. We have had residents do research in a number of different areas. Primarily, we have very robust experiences in surgical education, quality, surgical oncology, and transplantation. We are expanding our experiences in pediatric surgery research and trauma research. For the residents who are interested in doing global surgery research, I mentioned that it can run from 1 to 3 years. We've had a few residents who've done just 1 year out and then come back in. We've had residents go into certain labs and want to do 3 years of research in the pursuit of acquiring a PhD, and that's possible to do. So we don't actually build anything in specifically for a trainee. We want to make sure you get the experience you need. And we've had residents have an experience out at King's College in England as well. And that is, again, on a case-by-case basis, depending on your interest. Professional degrees can be attained, but they're not specifically funded by our department. And again, that's something that we work with the trainees on if it's an interest that they have. We have the ability for residents through the American Board of Surgery program for flexible rotations to try to do early tracking in their areas of interest. So this is done in the last 3 years of your clinical residency. And again, those are the specifics of those programs are all available on the American Board of Surgery website. But I primarily bring these points up about flexibility in rotations and early specialization so that you're aware they exist and that we're a program that's willing to adapt and allow you to experience that. And that's it for the quick informational session. So without further ado, I'm going to let us get to our breakout rooms. So I want to close the session by thanking everyone for joining us tonight. As you hopefully can tell, the residents and faculty are really accessible people, and they all know a lot about the program, and some know more about individual pieces of things than others. We are all more than happy to interact with any of you. Please feel free to reach out to any of us, but particularly Mary Ann will connect you with any of us if you have any specific questions that haven't been answered. I know the breakout rooms always feel like they go by way, way, way too quickly. At some point soon, we hope to have kind of a long form video that is the long bit of the teaser that you may see on our Twitter account that'll give people a little bit more information. But I want to thank you for joining us tonight and hope that we've piqued your interest in the program and answered any significant questions you may have. And one final thing, I know a lot of questions came up about the fisting program. There is, if you go on the American Board of Surgery website, there are little nitty-gritty details. And the last thing I really want to emphasize is the reason that's been not necessarily always employed by all of our residents at Emory is because we do have the kind of program that spans a number of campuses and a number of different clinical experiences. And so I think what you'll end up finding is the reason that not every resident wants to fist is because they get this broad, diverse experience that's going to get them what they need for their training regardless. And that's really one of the things that I found as a trainee in this program, and certainly one of the things that I've loved about it as an attending. I often tell people who ask me that I have never found another program that has made me wish I trained there instead. I am completely delighted to this day with the way that I trained and with the way we train our residents. And I love to hear back from the trainees to tell us that Delman set them up for success. I hope to do the same. So thanks so much, everyone. I really appreciate all the faculty who joined tonight.
Thank you so much.
Good night.
Of course, all the residents. Hopefully you'll notice they're not all in the hospital, which means we don't keep everyone locked in the hospital.
But I am. I'm in the hospital,
That's right.
Genevieve. What the heck? There you go. Thanks, everybody.
And thanks to Marianne, Vanetta, and Johanna really for organizing all of this.
Oh, you're welcome.
Thank you.
You're welcome.
Thank
Thank you.
Thanks,
All right.
everyone.
Bye-bye.
Good night, everyone.
Bye.